So my name is Annalise Sparks. I'm the social media and communications coordinator at the Joe Niekro Foundation. And for those of you who aren't familiar with the Joe Niekro Foundation, we provide education, awareness, and support for patients who have suffered from a brain aneurysm, AVM, or hemorrhagic stroke. We have a large community of survivors online, as well as 40 support groups across the U.S. And today we are super excited for our webinar with Dr. Chen, titled 10 Things to Know About Unruptured Brain Aneurysms. Dr. Chen is the Associate Professor of Neurology, Neurosurgery, and Radiology at Rush University Medical Center. And if you were with us last time, Dr. Chen spoke about ruptured brain aneurysms. So today we're going to be focusing on unruptured. And if you have any questions during the webinar, there's a chat box where you can type them, and we'd love to get questions throughout the entire webinar. So feel free to put them in there, and I'll relay them to Dr. Chen. So without further ado, I'll let Dr. Chen take over, and I'll give him the presenter rights. Just give us one moment.
Okay, wonderful. Thank you, Annalise. I really do appreciate the opportunity again to participate in this webinar. A couple weeks ago, we talked about ruptured brain aneurysms. Today, for the next 20 or 30 minutes or so, talking about unruptured brain aneurysms. That's a very important distinction. Obviously, with somebody with a ruptured brain aneurysm, it's an emergency, and the question of aneurysm treatment revolves more about when, not if. For an unruptured brain aneurysm, these are most often times discovered as an incidental finding on imaging of the brain done for various reasons, sometimes after minor trauma or unusual headaches. And then this usually leads to the consultation. Obviously, it can be very much an anxiety-provoking diagnosis to have. Sometimes this finding may really indicate something very serious, but oftentimes it also could very well be a benign finding that may not necessarily have a high risk for harm. So hopefully in today's webinar, my goal is really to try to emphasize and clarify certain key concepts that are helpful to know when you have, or somebody that you know has a diagnosis of an unruptured brain aneurysm. And this hopefully can be helpful in either understanding it on your own or providing some framework by which you can go to your doctor's office visit and have perhaps an even more constructive conversation. So to begin with, brain aneurysms are, as you probably know, a problem related to the brain arteries. Arteries are muscular vessels which transmit blood pumped by the heart to the cells of the brain. They're aligned with muscle, and they're designed to assume optimally a cylindrical, smooth shape to provide laminar blood flow. This is an important distinction to make with capillaries, which are like a web-like network of much, much smaller vessels, which is where oxygen transport occurs with the tissues or organs of the body. And after blood, which is under pressure in the arteries, passes through the high resistance capillary network, it then collects in the veins where blood without much oxygen passes through much more passively without pressure, and then goes to the heart to get pumped to the lungs, and the whole cycle continues. What makes the blood vessels in the brain unique, unlike anywhere else in the body, are these reconnections that occur after they've branched. This reconnection is actually of the four main vessels that go to the brain, both carotid arteries and both vertebral arteries. They actually reconnect at the base of the brain, and it's referred anatomically as a circle of Willis. Now, this is a wonderful network of redundancy that allows for continued flow of blood to the entire brain, even if there's a blockage or a problem with one of these arteries. The cost of this arrangement, however, is that instead of laminar blood flow, you can have a bidirectional and turbulent blood flow at these spots of reconnections. And that is, in fact, what leads to how aneurysms can occur at fairly predictable locations. The two most common locations for aneurysms are shown here on an illustration from Brisbane out of the New England Journal of Medicine in 2006, showing the anterior communicating artery as well as the posterior communicating artery locations are the two most common locations for aneurysms. to exist. And this really results from extra stress on those segments and the cells that normally line the walls of those arteries, no longer able to effectively remodel and maintain that smooth cylindrical shape, and this is what results. And these are all anterior communicating artery aneurysms, and you can see despite the similarity in their location, the shape and the size can vary substantially. This is, more of a sort of oblong shaped one here and a more of an ovoid one here. And same with the posterior communicating artery aneurysms. These are all similar location, a more ovoid one here, an oblong aneurysm here, and a multilobulated one here. So all of these many different shapes and sizes. This is a patient with the same patient with actually 3 aneurysms, 2 middle cerebral artery aneurysms and an anterior communicating artery aneurysms. So why is this a problem? Why do we need to be worried? The main problem is if these aneurysms were ever to rupture, it would lead to what's referred to as subarachnoid hemorrhage, which is a life-threatening condition. In general, a third of the patients don't make it to the hospital alive after a ruptured aneurysm. A third have substantial disability after the rupture, and a third do make a favorable recovery. It's obviously a life-threatening situation that if there's a means to prevent this from happening, it very much makes sense. The other main way that aneurysms can cause problems is what's referred to as mass effect. That's when an aneurysm, you can imagine it to be sort of like a balloon that's under the water faucet, and you have the pressure of the water transmitted to the edge of the balloon. Similarly, that sort of pressure effect can compress and at times cause dysfunction of neighboring brain structures or even nerves. It doesn't occur as often, and we're primarily concerned with subarachnoid hemorrhage. So you can see here from this nice illustration from the Barrow Neurological Institute that the arteries at the base of the brain near the circle of Willis really are sitting within the cerebrospinal fluid space that surrounds the brain. It sort of bathes the brain. So when bleeding from an aneurysm occurs, it really sort of finds its way and permeates into these spaces really surrounding the brain. The reason why it can be potentially life-threatening is because the skull is a fixed volume. So any increase in volume, namely blood, can very quickly, because the skull cannot accommodate that, the pressure starts to increase fairly rapidly in a linear fashion. And so you can see here on a CT scan, which is, by the way, the most common, most frequent way of diagnosis of a ruptured brain aneurysm. On the left, you see a normal CT scan. You can see here, hopefully this arrow shows these dark areas represent cerebrospinal fluid that normally surrounds the brain in these folds. And this is sort of near the circle of Willis. And this is somebody who's had bleeding from an aneurysm. And you can see this increased white signal here in these virtual spaces that sort of finds and that's basically what the subarachnoid hemorrhage pattern appears like. And this is how you make the diagnosis most often on a CT scan. The other main way that I mentioned that aneurysm can cause problems is via mass effect. And you can see here, this is not that subtle. It's a fairly large aneurysm right behind the patient's right eye. And you can actually see the effect of this aneurysm on the adjacent structures. And if you look closely, the right eye is protruding out a little bit more than the left eye. This is what the aneurysm looks like on a CT angiogram. And you can see on a catheter angiogram, just a very large aneurysm, and it's no surprise this is causing symptoms by local compression. So when one does have a diagnosis of an unruptured brain aneurysm, really the main question, the natural reaction is, boy, this is something I need to worry about. But that's hopefully what the visit to the physician office can really help to further clarify, because there are a good number of times that these findings may not need to be something to worry about. And what determines whether you need to be worried about it? It really has to do with symptoms. Is there a history of an unusual headache that occurred, which may indicate what's referred to as a sentinel headache? There may be other symptoms such as visual disturbances, double vision, a droopy eyelid, or anything to suggest, pressure on adjacent brain or nerve. When evaluating this aneurysm, oftentimes via brain vascular imaging, you can determine the size of the aneurysm, usually by its maximal diameter. And it's not just the absolute size that we pay attention to. We also look at the relationship between the aneurysm size and the artery that it comes off of. Obviously, an aneurysm of a certain size may mean even more instability if it's located off of a very small vessel. The location of the aneurysm, you want to make sure it's actually in the brain itself. Aneurysms referred to as cavernous carotid aneurysms are fairly common. They are very much more benign. They're located in the brain, in the skull region, outside of the brain region, and those have no real risk of bleeding into the brain. The shape of the aneurysm, sometimes we see if it's multilobulated, may suggest less stability, but something that's more smooth and broad-based may indicate that it may be perhaps a more stable structure. And we also want to pay attention to risk factors, whether there's a family history, particularly a family history of a ruptured aneurysm. We also want to see how the blood pressure is. Do you have somebody who has a normal blood pressure, a blood pressure well controlled on one medication, or somebody who's taking 3 or 4 medications to try to control their blood pressure, as well as a history of smoking. And when you are able to compile all of that information, that oftentimes gives you a sort of risk profile by which you can determine whether or not it's probably better to pursue a more conservative approach for the aneurysm or to entertain treatment options. And the goal of treatment, if that's decided upon, is to really exclude that weakened wall of the aneurysm from further contact with the normal arterial blood flow. So if the decision is to observe, that generally involves surveillance imaging, the modality you can decide upon. We can talk about that a little bit later. And usually those intervals of surveillance imaging, hopefully over time, if there's still documented stability, can gradually increase. If the decision is to pursue some sort of treatment to anatomically exclude it, open surgical treatment has been around for decades, but performed a little bit less in the mid-90s, and now it's really reserved for just the minority of aneurysms. We can go over that in more detail. Endovascular treatment has really become the more commonly chosen approach, and there are many different types of endovascular treatment for this. To go into this more and more detail, for open surgical treatment, craniotomy, you can see in the illustration again from Brisbane and New England Journal of Medicine in 2006. An incision is made in the skull to really, and that's sort of removed temporarily. And then, the surgeon is able to dissect down, oftentimes use a microscope to identify the aneurysm and place a clip, which brings together the walls of the normal artery and essentially strangles that aneurysm, no longer allowing any pulsatile arterial blood flow to enter the sac or have any pressure exerted on this weakened wall. If aneurysms, as you can see here, if they happen to be located close to the surface of the brain and in very experienced hands, this is oftentimes a very, very highly effective treatment approach. An endovascular approach, if done successfully, offers the same solution, but without having to undergo a craniotomy. You use existing spaces that exist within the body, namely from within the blood vessels, without having to create a space to get to it. And so you can see here, much like a cardiac cath, at the crease of the groin, a small incision about 1 centimeter wide is made on the skin, and then using wires and catheters, we're able to, under X-ray guidance, advance a catheter up to the arteries in the neck. From there, take pictures of the blood vessels in the brain. And then after appropriate measurements and evaluation is done, a small catheter is guided over a wire into the dome of the aneurysm. This is an example of what a biplane angiography suite looks like. And these are the large image monitors that we're able to use to really look at things that are on the order of millimeters in magnification, that really allows us to perform these procedures. This is the quick schematic video showing how a microcatheter is advanced under X-ray guidance over a wire in to select the dome of the aneurysm. The wire is then removed, and then through that microcatheter, we're able to advance soft platinum coils, which are appropriately sized to the patient's anatomy. These coils are then detachable. We can remove the microcatheter, and those coils stay as a permanent implant. They induce thrombosis, and most importantly, really serve as a physical barrier from any contact of blood flow to this weakened wall of the aneurysm. These are other additional pictures of aneurysms. This is the goal of treatment is to really only seal off the abnormal segment and still maintain blood flow through all of these important blood vessels. And the image to the right here shows what they look like in real life under high magnification. This is an example under catheter angiography of a basilar terminus aneurysm. You can see here fairly wide neck. We place the stent to protect this artery, and then coils, and you can see the final result, hopefully sealing off that defect. In 2011, the FDA approved the use of a newer approach for treating aneurysm. Instead of filling the sac of the aneurysm with coils or implant, this is what's referred to as a flow diversion solution, where it's only working within the parent vessel. It's a low porosity braided cobalt chromium construct that hugs the inner wall of the artery and really works to treat aneurysms by a different mechanism. It helps to, first of all, reduce the hydrostatic pressure that's exerted from within the artery here into the dome of the aneurysm here. You can imagine if you have a river and a little pool to the side, if you were to place a screen door at the entrance to that little pool, you would be able to really induce a bit more of a stagnant flow within that side pool, and that's kind of the goal here. But over long term, what allows us to be a durable solution is that it provides a framework for the endothelial cells, which normally line the inner wall of the artery, to then grow on top of this and really form a new cell layer to hopefully bridge this neck and create a complete cure in terms of remodeling new tissue here. So this is a lot more of an elegant solution in the appropriate patient, in that you don't have to sort of fill this large sac with implant. This is a classic example of a proximal aneurysm. This is actually outside of the brain itself. You can see the internal carotid come up here, take a little turn, come up here, and it gets a little narrow, and then it continues on up here to the arteries in the brain. And you can see here, after placement of a device, the pipeline device across this segment here, you're able to reconstruct what looks like a normal, almost completely healthy artery here, and really no filling in that sac that just clots off and heals off, and you didn't have to fill that whole thing with coils. So, you know, in select patients, it's a wonderful option. There are other options that are sort of being researched right now, but those are the two main approaches right now for treating aneurysms. So it's important during the office visit to really try to establish as best as possible your risk profile. Sometimes people may superficially say, oh, you have a certain 7-millimeter aneurysm, that means you need to do this. I think there's a little bit more that goes into that decision making. There's several variables that we like to consider, age being one of them. Obviously, if you're younger, there may be more for you to gain by preventative treatment of an unruptured brain aneurysm. In older patients, we also look at their level of functioning, whether they may be working, or some patients may not, may have some cognitive problems and may actually be dependent on many of their activities of daily living. We also look at the history of hypertension and smoking that may add to the risk. Family history, as we mentioned earlier, can further add to the risk. The details of the aneurysm anatomy are also what we factor in. We also want to factor in the anticipated treatment risks. Some aneurysms technically are fairly straightforward to treat if they have a narrow neck and they're fairly spherical in shape. But those that are, a little wider necked, they may be more fusiform or involve important arteries adjacent to it. They may be more complex technically to treat, associated with a higher risk of complications. And that needs to be factored in when you're talking about something which the whole goal is prevention. You also want to take a look at the comorbidities. If they have a lot of concurrent vascular disease, which may make an endovascular approach a bit problematic, you want to see if there's anything else that would factor in to whether or not it would make sense to undergo an invasive procedure, which does have risk, to hopefully reduce the future long-term risk of this aneurysm ever rupturing or causing mass effect. If conservative management is chosen, usually surveillance imaging is the main focus of that. And it's important to understand the difference between the three main ways that we have to visualize the blood vessels in the brain. The MRA is the least invasive. It's actually the safest approach. There's no ionizing radiation, and you can actually have fairly good quality images of the blood vessels without administering contrast. So even if a patient was a pregnant woman, this would be a safe study to pursue. It, however, does provide the least spatial resolution of the three modalities, and it actually can undercall lesions. CT angiography is also considered non-invasive. However, there is some amount of ionizing radiation, and you do have to administer contrast through an intravenous line, usually in the arm. It does provide a bit better spatial resolution, and it's a little bit more reliable and is less susceptible to false negatives. Catheter angiography is invasive. It does involve the incision in the groin and advancing a catheter into the femoral artery, up the aorta, up to the arteries in the neck. It does provide, however, not just the highest spatial resolution down to about 50 micron, like a strand of hair, but also provides information about blood flow, what we refer to as temporal resolution, in terms of how blood flows from the arteries to the capillaries to the veins. So outside of the decisions needed for surveillance imaging, we also like to pay close attention to blood pressure and really develop a plan and talk about it in more detail in terms of ways to be vigilant and proactive to try to optimize mass effect, and that may be an indicator to come back and seek medical attention to perhaps re-image the aneurysm, and that may indicate a reason to be more concerned and therefore consider treatment. Again, going back to surveillance imaging, I didn't mention it before, hopefully it should be fairly obvious. What we're really looking for is growth in the aneurysm, which may indicate instability, and again would push one to be more inclined to undergo the risks of treatment. So it's kind of a funny topic here. You're a physician, because I'm a physician, but I think it's important when you're undergoing a consultation for an unruptured brain aneurysm to really also take a look at your physician, because your physician's performance can also affect your outcomes. You want to get a sense of how long that physician has been in practice, how long they've been in practice outside of training. You want to get a sense of the focus of their practice too. Do they really focus just on cerebrovascular disease, or are aneurysms one part of a much broader practice that may or may not affect the focus? You want to get a sense of how they discuss and seem to manage complications. Is it something that they kind of a bit addressed in a more dismissive fashion, or is it something that that's acknowledged honestly, and there are prepared steps taken to hopefully mitigate it if it were to occur? You also want to take a step back and just observe their behavior. I think aneurysm treatment is fairly nuanced. It does take time. You've got to be very careful. There's really no room for mistakes, and you really don't want somebody who may be kind of rushed in how they do things. If they do things very quickly and abruptly, those types of things are also worthwhile to perhaps pay attention to. And you want to get a sense if the physician is involved in research, particularly brain aneurysm research. This really possibly reflects somebody who thinks very deeply about aneurysms is maybe borderline obsessive about them, and even thinks about them outside of when they're in the hospital or at work, to the point where they're really trying to search for better answers, which usually indicates a fairly deep understanding of the problem. And another question is it worthwhile to get a second opinion? It does take additional time and possibly resources, but if it's an unruptured aneurysm, it's generally something that's found incidentally usually, and you do have time, and it's usually probably, I would say, worthwhile to get a second opinion. If for anything else, not necessarily because you don't trust the first person you see, but it does help crystallize certain issues and concepts. Anytime you get that first consultation with the physician and they're talking about brain aneurysms, it's hard to retain a lot of what's discussed. A lot of times you're just thinking about the diagnosis and how it's going to impact your life, and a lot of what's mentioned in that first visit may go in one ear and out the other. And I think having that second chance to have a conversation again may allow you to sort of get past that sort of initial emotional reaction, and then perhaps have a more educated discussion about the really important concepts. And then also getting a second opinion, whatever decision you do end up taking, it may help give you a little bit more confidence in that. So this is something, it's an advantage in a big city. I practice in the city of Chicago. We got second opinions are fairly commonplace, but I think if you happen to live in a smaller town or city and there may be only one person in many, many miles that is referred to you as the only show in town, it may be worth thinking about traveling to a bigger city nearby to at least get a second opinion and get a sense of how this could be managed. This is certainly not something that's sort of a routine procedure like a colonoscopy or a joint replacement or something. It's fairly specialized. I mean, I think you could be fortunate if you have a fairly straightforward lesion, but you really don't know unless it's you're sort of evaluated by somebody who does this on a really focused, regular basis. So lastly is just the resources. It goes without mention that the Joe Negro Foundation is a wonderful resource, not just for support from other survivors who can relate their stories in a way that no physician could, but also provide background information, including webinars such as this. The Society for Neurointerventional Surgery also provides a lot of resources that help define some of these terms, and maybe provides a directory on physicians who help take care of brain aneurysms. And a couple other questions that oftentimes come up in the office consultation is, what is the value of screening family members? This is a very common question, and generally the recommendation is if you have 2 first-degree relatives, then screening is recommended, and it's usually in the form of an MRA, and you can probably do it without contrast to really minimize the upfront risks of that screening procedure. And what age is oftentimes asked. Aneurysms generally rupture at a peak age of about 52. It's considered a disease that you acquire over time, not something you're born with. So we generally recommend, and there's no real right answer to this, but probably around the ages of 30 would be a good time to perhaps start if the suspicion is high. And lastly, what are safe activities if one has a diagnosis of a brain aneurysm? It's really tough to say. I mean, people sometimes worry even about blowing their nose or doing anything involving any kind of straining. But in general, I think most of those activities are probably pretty safe. The only thing that we've seen anecdotally that specific activities, anything that suddenly raises your blood pressure. And we have seen it in patients who abuse drugs or take certain types of medications that cause a sudden elevation in their blood pressure. So that's really what I had, and hopefully that was something that everybody here finds somewhat helpful about 10 things to know about unruptured brain aneurysms.
Thank you, Dr. Chen. So we do have some questions. Thank you so much for that presentation. And on your last slide, you were talking a little bit about safe activities, and someone just had a question about exercising. Is it dangerous to exercise? Is it dangerous like hypertension is. If you could just touch on that a little bit.
I think before we can make any recommendations, it's probably best to have, if you do have an aneurysm that is being monitored with surveillance imaging, to have it evaluated. It could be anywhere between a 2 to 3 millimeter broad-based aneurysm near the base of the skull, or we could be talking about a 15 millimeter, anterior communicating artery aneurysm. Obviously, both of those, you may want to make different recommendations regarding exercise. If, however, it's thought to be an aneurysm that doesn't necessarily need treatment, but you're just keeping an eye on it, exercise, I think, is probably going to be okay, because you've probably had that aneurysm for some time. People oftentimes ask about sexual activity as well, and that's not anything that anybody has any strong recommendations to refrain from. And I think it's difficult to make these recommendations, but I think it's in general there shouldn't be. Flying is also a common concern, and I think with pressurized cabins, it's generally not really anything that should be considered relevant to inducing the risk of rupturing of a brain aneurysm.
Okay, great. Thank you. And then I don't know if your presentation is still up, but your audio went out on slide number 7, where you were talking about symptoms, I believe. And so people were just wondering if you could go over that again.
Okay, let me see if I can pull up that.
Yeah, it was number 7.
Okay.
Yes.
Okay. Okay, the warning signs. Is that the symptoms that you're referring to?
I believe so, if everybody.
Okay.
I think so.
Yeah, the warning signs generally has to do with the location of the aneurysm in relation to the brain and any adjacent nerves. So if the aneurysm, for example, is in the posterior communicating artery, and it's thought to be quite small and it's a kind of a low risk profile overall, then if that were to get larger, sometimes it can cause pressure on the third cranial nerve, and that would potentially lead to a droopy eyelid, a dilation of that pupil, and maybe even double vision, and the fact that that eye may not move as well as the other eye. And so it really depends on the location of the aneurysm that will lead to specific types of warning signs that one might want to remember and pay attention to. And if you feel any of those symptoms come on, it's not just because you're tired or you slept wrong, that you probably should get seen sooner than later. But I mean, having said that, unfortunately, there's usually very little almost all patients with ruptured aneurysms have no warning sign prior to rupture. Only in a minority of cases do you have that.
Thank you. So back to the questions. Someone asked, with the flow diverter, when you were discussing about that, were you saying that the aneurysm will eventually go away?
Yes, that's actually what happens, and it sounds too good to be true, but basically what happens is once you no longer have active flow within the sac of the aneurysm, blood has a property when it's static to begin to clot. And once it clots, it activates an inflammatory response, and the body's own immune mediators and inflammatory mediators come in to essentially digest that clotted piece, and it eventually seals itself off, and it's no longer there. And actually, in some cases, really relieves the previous pressure that was exerted on surrounding nerves or brain.
That's really interesting. Is this the standard practice now, or still coiling?
It really depends on it. Yeah, it really depends on the aneurysm. Sometimes there may be arteries next to it that make flow diverter less optimal. It really should. Having said that, I think when flow diverters were initially FDA approved in 2011, there was some question as to how widely they would be used, but I think most physicians would agree over the last 5 years, the indications and use of flow diverters have really probably surpassed most people's expectations. It is a much simpler and in many ways possibly safer and probably more durable treatment approach compared to coiling, especially for large aneurysms. What can happen with coiling for wide neck aneurysms is that the coils may over time begin to what we call compact and potentially then leave some segments of the aneurysm dome exposed to blood flow, arterial blood flow. But that generally is not the case for flow diverters. And I think people's familiarity and understanding of it is increasing. And there are other flow diverters with slightly different technical modifications that will probably soon be coming to the market as well. So this definitely represents a paradigm shift in aneurysm treatment from an endovascular approach. And there are others, that likely will come on the market as well.
Okay. Another question in regards to the flow diverter. So do fusiform aneurysms decrease in size if a diverter is used?
That's the goal, and I think if everything goes well, that's generally what happens. Hopefully that segment that's fusiform, has a well-defined normal segment just past the fusiform dilatation, as well as a normal segment just before the fusiform segment, such that you can sort of anchor your flow diverter, across that fusiform segment. It can be challenging. These can be technically a little more difficult because it's sort of this large expanse of space that you're trying to bridge with a device. You don't have the normal sort of walls of the artery to help mold, what you're trying to accomplish. So, but that's the goal, is to sort of re-establish that normal cylindrical shape of the artery with the use of this device. Okay,
thank you. We have a couple more questions. Someone asked, do clips on unruptured aneurysms ever come off or get knocked off by a blow to the head?
That's really, fortunately, really unheard of. I think anything's obviously possible, but it's important to consider the fact that aneurysms and the clips on unruptured aneurysms are sort of, for lack of a better term, floating in this cerebrospinal fluid space within the skull. So even a blow to the head would really transmit pressure, really along the entire skull, and in sort of wave-like fashion, transmit a sort of a generalized impulse to any structure within the skull itself. So it's unlikely that it would be able, that force of that fall to the ground would likely transmit a very generalized force, unlikely to dislodge a clip. The clips are fairly precisely placed, and they have a very strong gripping power, and so I think it's generally not something that you hear of. I think the question then is, what is the risks of any type of exercise that may potentially involve head trauma, such as playing soccer or football, if say a young person has an unruptured aneurysm that's clipped. And again, it's hard to generalize. I'd probably just make sure you get that question addressed with your physician who took care of the aneurysm to begin with, and they may be able to provide a more definitive response to that kind of question.
Okay, great. Thank you. Someone asked in regards to the clip, if it doesn't entirely cover the base, can the aneurysm grow back?
That can occur on occasion, and we have seen oftentimes a follow-up angiogram is performed after a clip is placed, and we do on occasion, fortunately not that often, see a small portion of the neck that is not necessarily completely addressed with the clip and still has some filling. and those can oftentimes be managed either by replacement of the clip, or even in some cases placing coils within that small neck. And usually that's a fairly straightforward embolization case, coil embolization case, because the neck has basically been made for you, and the coils usually stay very safely within the dome. But that can occur on occasion, but generally that issue is resolved after obtaining a post-clip angiogram.
Okay, thank you. We have a couple of questions in regards to getting an aneurysm. Is it possible to get an aneurysm from an accident? And are there any studies that have been done linking sports or head trauma to brain aneurysm development?
Well, I think sports and trauma can cause blood vessel artery problems, and it's usually referred to as a dissection, and that usually involves a tear in the artery and a separation of those one of the three layers. The innermost layer is referred to as the intima, the middle layer, the muscle layer is called the media, and the outer layer is called the adventitia. And you can have a separation of those layers from trauma, and that can lead to what's called a dissecting aneurysm. Those generally occur at the base of the skull, where it's tethered to one end and mobile at the other. Generally not something that you see in the brain itself, with the from just sort of head trauma, from sports and things like that. So it's usually not much of a concern. I think what we worry most about is somebody who may have a predisposition in terms of why they form on average. It's usually somebody with a predisposition, usually with a family history. And that speaks to the integrity of the artery. And then years of hypertension and perhaps smoking, which then causes added pressure on the wall and maybe increased inflammatory activity. And then that can all sort of then lead to the aneurysm forming. It's usually multiple reasons why an aneurysm forms, usually not, I would think, just one specific reason.
Okay, thank you. One last question. Someone's asking, when is glue ever used?
Glue is most commonly used nowadays for what's called arteriovenous malformations, when you have an abnormal connection between the artery and the vein. It had been used at one point. It's called a Onyx HD 500 for the treatment of aneurysms, and it did have a lot of appeal in terms of creating a more solid cast that would potentially be more durable than a nest of coils. It is a little bit more technically involved to perform. You have to inflate a balloon in a normal artery to create a seal such that any glue that's injected within the dome of the aneurysm does not leak out and potentially affect normal arteries. But it's really not something that's caught on among most practitioners. I think perhaps 5 years ago is when there was a lot of interest in glue for aneurysms, but nowadays it's, I think, some combination of either coiling, stent-assisted coiling, flow diversion, or some other newer devices that have, that really exploit the local anatomy to achieve the goal of aneurysm embolization.
Okay, interesting. Thank you. We have one more question, if you don't mind. This will be the last one. Someone is wondering, can aphasia, dizziness, and headache be associated with unruptured aneurysms?
Yeah, I mean, I think that's the challenge with neurological diseases. Unlike cardiac disease, where it's the amount of symptoms are fairly straightforward. You have either chest pain, shortness of breath, or pain radiating down your left arm. For when it comes to brain dysfunction, any of those symptoms, among many others, could potentially represent either something serious or maybe something more benign, including something like a migraine. It's really hard to say for sure one way or another, but I think generally from what you're describing, those symptoms sound like something that probably should be evaluated in more detail by a physician. and they can decide whether any type of, based on their suspicion, on after talking with you in more detail, asking the right questions, and performing a neurologic exam to see if you have any deficits, to then decide what type of imaging or any other investigations would be worthwhile to answer any kind of suspicions that they might have, to get to the bottom of it. But anytime you develop those types of symptoms, especially aphasia, we tend to worry about something that may be going on in the brain. There could be some benign things, but could be something serious. You just need to sort it out.
Okay, thank you. So that concludes our webinar today. I just want to thank you, Dr. Chen, for taking the time this month to do 2 webinars with us. We really appreciate it, and we know our community has been very excited and wanting to view the recordings right afterwards. So I would just like to thank you for taking the time to do this during Brain Aneurysm Awareness Month.
You're welcome. My pleasure.
Thank you, everyone, for attending.